Hello, welcome from CVI 2017. We're sitting here with Dr. Leif Christianson from St. Luke's Heart and Vascular Center in Duluth, Minnesota. He'll be talking about PCI of chronic subtotal occlusion of the left main coronary artery.
Hi, thanks very much for having me. So I'll jump right into the case here. This was a patient I saw in one of my first months at the new hospital after training. He had previously been seen by one of my colleagues who had since moved on to another position. And essentially he's a 62-year-old male. He had recently had a 4-vessel bypass that was performed in the setting of stable angina in February of 2016, where he had edema to his LAD and vein grafts to a diagonal artery, his second obtuse marginal artery, and his posterior descending artery. He also had risk factors of tobacco use, which he continued to smoke even after this, hyperlipidemia and hypertension. So when I saw this gentleman, he came in with complaints of new onset, shortness of breath, and angina. His primary care physician had ordered a nuclear stress test on him, which showed a large area of ischemia involving the anterolateral and lateral walls. So in that initial clinic visit, I started him on kind of optimize his anti-anginal medications and planned for an elective angiography. He also had an echocardiogram done, which was essentially unremarkable. He had normal LV systolic function. So this was his angiogram from the year prior, before he received bypass. As you can see, he has very tight distal left main there. He has some disease in the proximal mid-LAD there. And for brevity's sake, I didn't show the rest of the pictures here, but this is kind of what led to his getting his bypass operation. So fast forward to a year later, this is the angiogram that I performed on him, and as you can see, he has essentially an occluded left main artery. I call this a subtotal occlusion because, as you can see, there's this kind of a wisp of dye flowing into the circumflex artery here, but a very tight blockage. This is his lima, which looks great, good antegrade flow. And as we'll get into later, this is not the order that this was done in. Sorry, this is the order this was done in. I had a difficult time finding his vein grafts to the diagonal and obtuse marginal arteries, so I kind of took what I got using the catheters that I had. But at this point in time, I wish, after finding out what his anatomy looked like, that I would have taken a few more images of this, essentially to show more of the bifurcation of the LAD and circumflex arteries. Here's one of his vein grafts. I assume that this one was to his diagonal. I never did find the one to the obtuse marginal artery. We did an aortogram, and essentially there wasn't anything there. This is his vein graft to his PDA, which looks good. So after trying to hunt for all of these grafts, he'd been given quite a bit of contrast load. I decided to stage this procedure and bring him back. And it also had become apparent this gentleman had very poor dentition with multiple caries and abscesses in his mouth. And around the time that we were doing this, he mentioned that he was planning on having a full dental extraction. So I needed to speak with his oral surgeon, not only to kind of figure out how we could plan this procedure, if they would be willing to do it before I did my work, or if it needed to be done afterwards, like we would have to use bare metal stents. Unfortunately, Duluth is not a large town, so there's only a couple of oral surgeons, and no one was willing to do this operation on him prior to his PCI. So we were kind of stuck with that. So we brought him back to the cath lab. We decided to do this as femoral access, of course. Used a 7 French guide. And the initial plan was to use a long pilot 50 wire to get in, with plans to put wires both into the LAD as well as the circumflex. The pilot 50 wire did not cross. I was able to get a long Fielder XT wire through that micro channel, and then this was exchanged out with use of a fine cross micro catheter, eventually putting a run-through wire in. Now, as you'll see in the next picture here, I wasn't able to get a wire into the circumflex artery. It was just too tight of an angle to get. Once I got through the left main, there was no way to get into the circumflex, despite multiple attempts. And as I'll talk later, this was another thing that I wish we would have had, kind of an angled microcatheter that might have kind of pointed me in the right direction, which might have made this a little bit easier, or at least would have taken the stress out of this procedure a little bit, because as the next thing, since I was only able to get a wire down the LAD, I decided to go ahead and balloon and just kind of hope for the best that I didn't close off the circumflex. So it's kind of one of those things where you hold your breath for a second or two as you're doing this. This is the wire in the LAD, balloon going up there right at the bifurcation, and fortunately this is the next shot. We have flow here, and the circumflex looks pretty good actually. So a second run-through wire was advanced into the circumflex. We did multiple balloon inflations in the left main and circumflex arteries. It's just kind of pre-dilation. It's kind of showing all of that. Getting a fairly good result here, and we did have to use guideliners to kind of help deploy things into the proximal circumflex there. We implanted 2 bare metal stents in the left main and in the proximal circumflex. Here's the deployment there. And there's the result of the left main and circumflex there, which at this point is looking pretty good. Now we did do, I did do IVUS at this point just to make sure that, particularly in the left main, that the stents were, both for vessel sizing as well as stent expansion, et cetera, that this was, that we were on the right track here. And indeed, things look pretty good here. Some non-compliant balloons here, just kind of tacking things up. And we did final kissing balloon inflation here, kind of busting the struts at the bifurcation there, and then again, just kind of trying to expand things as best as possible. Here's the final result here.
Very nice.
So he went home the following day, aspirin, decided to use Brilinta on this gentleman. Unfortunately, he's statin intolerant. As I say here, working on Repatha, he was declined Repatha because his lipids were too good, and sent him home on optimal medical therapy. He got his dental extraction 6 to 8 weeks later, and immediately started dual antiplatelet therapy. I've seen him in clinic a few times since then, and he's done very well with no more symptoms.
Great. That is a great case and a great result. A couple of questions. What was the thought process behind using bare metal stents, and why the need to use 2 separate ones instead of a single long one?
Some of that was, I felt that, in the end, it was, we used the same size, so I probably could have gotten away with a longer one. The other problem was getting the stents to actually get into the circumflex. I was having to use a guide liner just to kind of get me into the right position. And I can't remember if I tried using longer stents or not, but there was issues with delivery.
Definitely delivery is a big decision in terms of deciding stent length. And I'm assuming the bare metal choice versus drug-eluting was because he was going to require this oral extraction.
Correct. And they wanted him off of dual antiplatelet therapy, or at least off of his Brilinta,
Right.
which is really unfortunate doing a left main case, obviously, that you're put in this position, and you have to put a bare metal stent in there, which is obviously less than ideal.
Right. A couple of questions on the beginning of the intervention. Was there any thought to considering access in the left radial and doing dual angiography with Lima and left main at the same time? To lay out the lay of the land, as you know, this is an established CTO technique that we do to set up our CTO intervention. It can really connect the dots nicely, give you a nice layout of the true length of the occluded segment, and then also guide your intervention, especially as you're trying to wire into the circ. That might have been helpful. What are your thoughts on that?
I think it would have. I hadn't thought about doing that, and as I mentioned, not really knowing what the ostium of the circumflex looked like based on my prior angiography, I think that would have been helpful to do, again, just to kind of lay out the land and see exactly where.
It definitely would have been helpful here. And one of the considerations when you have a difficult angulation in a diseased distal left main, and you're right on point about an angulated catheter, venture catheter, as you know, the venture catheter is recalled right now, and so, but that is, as you know, a deflectable catheter that works really well in those scenarios. currently recalled, but that company also has a catheter that is angulated. I don't know if your lab has it. It's called Supercross.
Yeah,
and can work well.
we have since gotten them after this.
Great, great. All right. Well, thank you for that great case. Great result on that.
Thank you very much.
All right.